Good morning. So as Jaime said, I'm going to be talking about the research that I've been carrying out over the past few years here at Carleton with Kim, Matheson, and Jaime, with much of our work exploring the prevalence and impacts of contemporary discrimination, as well as the impacts of past collective discriminatory policies in contributing to mental health disparities that exist between Aboriginal peoples in Canada and the general population. So I'm going to start off first by saying that we have not directly explored the issue of mental health stigma in Aboriginal peoples in Canada. And as pointed out by Mike, there's actually very little research exploring this specific topic. However, research conducted among other Indigenous populations suggests that mental health stigma and the internalization of this stigma likely contributes to health disparities by influencing help-seeking behaviors. And there's some evidence that this is also the case in Canada as well. There's also a gap in the literature regarding experiences of Aboriginal peoples when accessing mental health services. Again, research among other Indigenous populations in conjunction with Canadian studies exploring interactions with other types of health services suggests that stigma related to one's Aboriginal identity can influence the care they receive and in turn influence the likelihood of them accessing help in the future. So as previously described, stigma can come in many different forms, but is usually manifested through stigmatized attitudes, stereotyping, or labeling. Even in today's society, stereotypes persist that Aboriginal peoples are cold or unfriendly, dirty or lazy, or are violent or dangerous. For example, when I was preparing this talk, I came across this t-shirt being sold on the internet that reads, "My Indian name is Crawling Drunk," and I'm not sure who they're trying to sell this to. But so scholars have suggested that the image of the drunk Indian is one of the most enduring colonizing images pervading Canadian public perceptions, and stereotypes such as these were reported by Aboriginal peoples in Winnipeg to be a major source of distress. So although we like to think that our healthcare system is free of such biases and prejudice, as I will discuss, unfortunately, such stereotypes can also influence the care that Aboriginal peoples receive when interacting with healthcare providers. So stigma is often apparent when individuals or groups are excluded or treated differently to the norm, which is a form of discrimination. So in contrast to stigma, discrimination involves the negative and disrespectful actions committed against you. And research has shown that discrimination against Aboriginal peoples is very prevalent, which compounds their disproportionate exposure to other types of general stressors. For example, a survey of Canadians revealed that Aboriginal peoples are thought to be the second most discriminated against group in Canada, and were ranked as the most discriminated against group in certain provinces, including Manitoba and Saskatchewan. In line with the views of Canadians, one of our smaller studies of Aboriginal peoples from across Canada found that 99% reported experiencing at least one discriminatory experience in the past year. And finally, research has shown that discrimination is prominent in many different facets of life for First Nations peoples, including education, employment, at every level of the justice system, and in the healthcare system as well. So while relatively blatant instances of discrimination still exist, it appears that microaggressions, which refer to the more subtle everyday slights and denigrating messages that are sometimes delivered, sometimes unconsciously by majority group members, tend to be more common in today's society. So to explore these type of experiences, we presented with Aboriginal peoples with a variety of scenarios depicting potential microaggressions, and found that in general, Aboriginal peoples perceive these types of events to be quite common. So for example, we asked participants to imagine that they were walking around in a department store and that they'd noticed that they are being followed. So it's not known for sure why this person may be following you, which is one of the core characteristics of microaggressions, that the situation is ambiguous. So there's always that nagging question of whether it really happened, whether they're targeting me personally or because of my group membership, or perhaps maybe I'm just being paranoid. So this is what makes these experiences so insidious, is that the victims often don't know how to appraise the the situation or how to respond. So in our sample, over half agreed that this was a type of thing that happened to them in the past year. So other types of microaggressions that have been identified include instances where majority group members deny or minimize discriminatory events, which can invalidate experiences of minority group members and puts the burden on them to prove that racism is still an issue, and this was also quite common. And a related form that was also quite prevalent alleges oversensitivity among minorities. So in Aboriginal peoples, there's often a stereotype of constant complaining, which basically just reflects ignorance and misinformation related to historical events and Aboriginal rights, as well as inaccurate assumptions that most Aboriginal peoples are prone to substance abuse, have low levels of education, are non-tax-paying members of society, and are dependent on social or governmental services. So it is in this context that many Aboriginal peoples negotiate the social world, and unfortunately, the healthcare system does not seem to be an exception. So not only are these experiences of discrimination and microaggressions very common among Aboriginal peoples, but we also found that it has a detrimental impact on their mental health, as we found that higher levels were associated with higher depressive symptoms in our samples of First Nations adults. And furthermore, discrimination has been associated with a range of other negative outcomes, including suicidal thoughts and behaviors, alcohol abuse, gang involvement, and even physical conditions such as diabetes. So in addition to our research exploring contemporary instances of discrimination, we have also explored how an example of a relatively recent collective trauma experienced by Aboriginal peoples continued to impact subsequent generations. So before I present some of these findings, for those of you who may not be too familiar with this issue, Indian residential schools were church-run, government-funded schools that ran in Canada from the mid-1800s until the last school closed in 1996. It's estimated that at its peak in the 1930s, approximately 1/3 to 1/2 of Aboriginal children were in these schools. In 1996, the report of the Royal Commission on Aboriginal Peoples included a chapter which reported the widespread abuse and cultural suppression that happened within the residential school system, and also discussed the traumatic effects that residential schools had on the children, their communities, and on succeeding generations. And just speaking to the significance of this policy today, based on the 2008 First Nations Longitudinal Health Survey of adults living on reserve, it was found that just over 2/3 of adults were either residential school survivors themselves or were impacted intergenerationally. So consistent with such personal and anecdotal accounts of such intergenerational impacts, we found that children of residential school survivors exhibited greater levels of depressive symptoms. And interestingly, we found that they are also more likely to perceive higher levels of discrimination, which in turn contributed to their heightened depressive symptoms. Similarly, in a separate study we carried out surrounding the residential school apology that was delivered by the Prime Minister, we found that increased perceptions of discrimination among participants who had a loved one who attended residential school was associated with decreased levels of trust towards non-Aboriginal Canadians, and which likely reflected a bi-directional relationship between these two variables. So considering that trust in others is fundamental in determining good relations, these results suggest that collective or historic intergroup experiences are tied to current intergroup dynamics and relationships. So in contrast to public stigma, self-stigma occurs when you internalize and begin to believe the negative opinions about you and start to think that you deserve to be called names and denied opportunities. And this is often accompanied by feelings of shame or guilt. So shortly after the residential school survivors began to receive compensation for the government for their time spent in these schools, we interviewed survivors from across Canada to assess the impacts of these payments that they received. And a common issue that was discussed by many survivors was that during the application process or after they received these payments, many experienced the reemergence of feelings of shame and guilt that they had to live with throughout their lives, which stemmed from their experiences of abuse in residential school, and also from the constant messages delivered in these schools that Aboriginal peoples are savage or inferior. So at least in this specific population, internalized stigma related to being Aboriginal was quite prevalent. So of course, such discrimination and internalized stigma contributes directly to mental health disparities. However, based on research in the US and Australia, another possible determinant of the poor mental health status among Aboriginal peoples is their underuse of mental health services in proportion to their need. For example, research among American Indians suggests they are more likely to delay seeking treatment until their symptoms are severe. They're less inclined to seek treatment from mental health specialists, and they experience higher non-return rates than those of other populations. And so there is some evidence of similar issues happening here in Canada as well. So related to this, some research has found that stigmatizing attitudes about mental illness vary across population subgroups, including those defined by race and ethnicity, with the majority of studies suggesting that minorities tend to hold more stigmatizing attitudes. While there are various obstacles to seeking treatment, including accessibility and cost, perceived stigma and self-stigma about mental illness may also prevent affected persons from seeking or completing treatment, which may ultimately contribute to disparities. And although the relative prevalence of mental health stigma is unknown among Aboriginal peoples in Canada, research exploring mental health service utilization, again in the US and Australia, suggests that a shame factor or stigma related to mental illness also prevents Indigenous peoples from accessing mental health services. For example, on and off-reserve American Indian adolescents reported suicidal thoughts and behaviors, cited embarrassment and stigma as central reasons for avoiding formal and informal mental health care or support. For example, a female 17-year-old participant in this study from a large city expressed concern that everybody would know, and a 16-year-old living on reserve explained that she did not confide in family or friends because she was worried that they might think she was crazy or something. So similarly, among Indigenous adults in Australia, shame was the second most reported reason for not accessing mental health services. So returning to the interviews from our study exploring the impacts of the compensation that residential school survivors received, similar concerns related to shame, internalized stigma, and fear of others finding out or gossiping were raised in discussing support seeking for their ongoing distress. Related to these concerns about stigma is the fact that in some of these isolated Aboriginal communities, it's difficult to confidentially or anonymously seek or receive services, especially among those who have limited mental health resources. So furthermore, among other Indigenous populations, it seems that mental health stigma is often accompanied by apprehensions and distrust about service use because of historical abuses, lack of familiarity with mainstream services, and apprehensions and distrust due to previous experiences with service providers that were not culturally competent or sensitive. Again, in the US and Australia, a general lack of trust in mainstream services, stemming partly from previous experiences of discrimination in these contexts, were reported to draw individuals away from these services. So although not exploring interactions with mental health service specifically, research suggests that Aboriginal peoples in Canada also experience discrimination in various healthcare settings. For example, in one such study, an Aboriginal male described how he went to an emergency department with a really bad headache, only to be sent home after health workers suggested that he was drunk. He went on to recount how he returned to another hospital the following day where, after his headache had gotten worse, where they took him in immediately to be operated on. So of course, it's not unusual that errors will be made, but what is not acceptable is that they sent him home based on a stereotype. So in this same study, healthcare providers were interviewed about their experiences when interacting with Aboriginal patients. Whereas some were culturally competent, the authors noted how many healthcare providers took for granted that everyone is treated the same, irrespective of their background or social position. And these responses from healthcare providers are akin to the type of microaggressions I described earlier, in which Aboriginal peoples are conceived of as complainers, and their unique historical and contemporary experiences and the resulting socioeconomic and health disparities are ignored. Supported by the observed intergenerational impacts of past collective traumas endured by Aboriginal peoples, these inequities cannot solely be explained by personal choices, which was suggested by another healthcare provider in this study, but rather reflect the long-standing discriminatory practices and policies that have exerted their effects at personal, interpersonal, and systemic levels. So far we've discussed how mental health stigma and stigma attached to other social identities, in this case being Aboriginal, can independently contribute directly and indirectly to poor health outcomes. However, it has been suggested that individuals who are already marginalized in society and who then develop a stigmatizing condition might experience a layering or double burden of stigma. Again, this issue has not been explored among Aboriginal peoples with mental illness specifically, but another study in Canada, which looked at the issue of double stigma, reported that an Aboriginal man living with HIV described how he faced a stigma within a stigma. So in addition to the independent impacts of these stigmas, stereotypes of Aboriginal peoples being drunks, dirty, or licentious might magnify and drive the stigmatization of persons living with HIV and AIDS, limiting their abilities to resist this stigma or promoting internalization of this stigma. And of course, although it hasn't been looked at, this phenomenon may also apply to Aboriginal peoples with mental illness. So finally, there's evidence that the impact of stigma may affect groups differently. For example, it was reported that internalized stigma related to being an American Indian was associated with the tendency to regard one's life chances as fatalistically ruled and with a tendency to experience social anxiety. However, internalized stigma was not related to these variables among African American or European Americans. The authors of the study suggested that this differential impact of stigma likely reflects the continued collective socio-psychological disadvantages and the high levels of discrimination that continue to be experienced by Aboriginal peoples. So basically, what we can conclude at this point is limited. We already know that discrimination and stigma related to being Aboriginal contributes to poor health outcomes. However, it also seems that stigma related to mental illness may also contribute to health disparities, suggesting that there's a need for further exploration of this issue in Aboriginal populations. So thank you for listening today. Any questions?